Bismillahirrahmanirrahim. This is me, Muhammad Asif Jib, and I am working as a lecturer at the Institute of Paramedical Sciences. In the hematological series, this is our first lecture, and our topic is iron deficiency anemia. In this lecture, we will cover iron metabolism, pathophysiology of iron deficiency anemia, and the diagnosis of iron deficiency anemia. Before explaining iron deficiency anemia, we should know that what is anemia. Anemia is defined as decrease in hemoglobin concentration according to the age and gender of the individual. Age is important because different age groups individuals have different level of hemoglobin. In children, the level of hemoglobin is increased as compared to adults, because in children all bones are responsible for the process of erythropoiesis. In children, long bones, short bones, flat bones are responsible, while in adults only flat bones are responsible for the process of erythropoiesis, although long bones can also perform erythropoiesis, but not just like flat bones. Gender is important because male have different level of hemoglobin while female have different level. In males, there is a hormone which is known as testosterone hormone. Testosterone hormone can also stimulate the process of erythropoiesis just like erythropoietin. Erythropoietin is also a hormone which is mainly responsible to stimulate the process of erythropoiesis. While in female, the level of hemoglobin is decreased because in female there is menstruation cycle, which also leads to decrease the level of hemoglobin. Therefore, these two factors play a major role to define anemia. Anemia can be classified according to on the basis of their etiology and on the basis of red blood cells indices. Based on red blood cell indices like MCV, MCH and MCHC, we can classify anemia into three types: macrocytic anemia, normocytic anemia and microcytic anemia. Macrocytic anemia is that of anemia in which the level of MCV is increased than the normal, while the normal level of MCV is 76 to 96 femtoliter. So if the level of MCV is higher than 96, we classify that anemia as macrocytic anemia. But if the level of MCV is between 76 to 96 femtoliter, that anemia is classified as normocytic anemia. While in microcytic anemia, the level of MCV is less than 76 femtoliter. Therefore, in microcytic anemia, there are four types of anemia, that is iron deficiency anemia, thalassemia, sideroblastic anemia and anemia of chronic disorder. In microcytic hemochromic anemia, iron deficiency anemia is the most common type of anemia. Now, what is iron deficiency anemia? Iron deficiency anemia is that of anemia in which the body stored iron is exhausted. It means that body storage iron is decreased than the normal. So that anemia is classified as iron deficiency anemia because the main causative agent is the level of iron, which is decreased. So iron deficiency anemia occur most commonly in females. So all females, the percentage of anemia is 20%, while pregnant females, 90% of iron deficiency anemia occur in pregnant female, while the percentage in male is 3%. Before discussing the pathophysiology of iron deficiency anemia, we should know that what is the metabolism of iron. So if we know the metabolism of iron, we can easily understand the pathophysiology of iron deficiency anemia. These are the daily requirements of iron in milligram per day. In adults, normally, adults male, postmenopause females, menstruation females, pregnant females, children, and females of age 12 to 15 normally lose iron in milligram per day. Normally, all these individuals lose iron in urine, sweat, and feces during menstruation, during pregnancy, in growth, and this is basically the total loss of iron per day. A normal adult male lose 0.5 to 1 milligram of iron in urine, sweat, and feces, while postmenopause female also lost 0.5 to 1 milligram iron per day. Menstruating female lost 0.5 to 1 milligram per day iron. In addition to this, they also lost 0.5 to 1 milligram iron during menstruation cycle. Pregnant female lost 0.5 to 1 milligram. In addition, 1 to 2 milligram iron is also lost because the baby also need iron, which is transmitted to the baby. So total daily lost iron in pregnant female is 1.5 to 3 milligram per day. In children, 0.5 milligram per day iron is lost in urine, sweat, and feces, while for growth, 0.6 milligram iron per day is required for their normal growth. So total iron loss is 0.5 to 1 milligram. In female during the age of 12 to 15 years, total iron loss is 1.6 to 2.6 milligram per day. Now, when will iron deficiency anemia develop? So iron deficiency anemia will develop in these individuals if the daily loss of iron is increased than the intake. An adult male usually ingests 15 milligram of iron per day if they take a balanced diet. So our body will absorb only 10% of that iron. So 15 milligram of iron if ingested, so our body will absorb 1.5 milligram of iron, which is the daily loss, which is equal to the daily loss. So when iron deficiency anemia will be developed, iron deficiency anemia will be developed if our diet is not, if we do not take iron in our body, in our diet properly. So iron deficiency anemia will be developed. Iron absorption. That how iron is absorbed in our body. Our body absorbs iron in the small intestine, and in the small intestine, duodenum is responsible to absorb iron. 3 किस्म के आयरन हमारे डाइट में मौजूद होते हैं, Fe2 के फॉर्म में और हीम के फॉर्म में और Fe3 के फॉर्म में, लेकिन Fe2 के फॉर्म में बहुत ही कम मिकदार में। सो मेनली हम आयरन 2 सोर्सेज से लेते हैं, नंबर 1 एनिमल सोर्स एंड प्लांट सोर्स। एनिमल सोर्स में मोस्टली आयरन हीम के फॉर्म में पाया जाता है, वाइल प्लांट सोर्स में मोस्टली Fe3 के फॉर्म में। Fe2 के फॉर्म में आयरन डाइट में मौजूद नहीं होता, हाँ फार्मास्यूटिकल तरीके से Fe2 में हम ले सकते हैं। अब ये एक सेल है स्मॉल इंटेस्टाइन के ड्यूडेनम के पार्ट का, एक एंटेरोसाइट हमने लिया है, ये ब्रश बॉर्डर है। We can say that there are some channels present on the brush border of the enterocyte. One is this one and the other is this one. This channel is basically specific for heme. Therefore, this channel is known as heme transporter because this channel transports heme into the enterocyte. While this channel is specific for divalent metals, for example Fe2, like magnesium, this is known as DMT1, dimetal transporter 1, and this dimetal transporter 1 is also known as cytochrome B. Dimetal transporter 1, sorry, not cytochrome B. Cytochrome B is basically fury reductase enzyme. This dimetal transporter 1 is also present on other cells where iron is required. In Fe3 form, iron, this Fe3 form, which is known as ferric, this is first reduced into Fe2. The enzyme which is responsible to reduce this Fe3 to ferrous form is known as fury reductase enzyme, which is also known as cytochrome B. This Fe2 is then transported into the cells through this DMT1 transporter. Heme directly enters through this channel, which is known as heme transporter, into the cell. Upon entry into the cell, this heme is digested by an enzyme known as oxygenase enzyme or heme oxygenase enzyme, and iron is released into this enterocyte. This iron is then transported into the peripheral circulation. But before entry, we can say that there is another channel which is present on the apical surface of the enterocyte. This channel is basically regulated by another hormone known as hepcidin. Hepcidin is mainly secreted by the liver. This hepcidin regulates the entry of this iron into the peripheral circulation. If our body needs much iron, so hepcidin regulate this iron, because this hepcidin also regulates another protein which is known as apoferritin. Apoferritin is the part of ferritin. Apoferritin plus iron is known as ferritin. So if our body needs more iron, this hepcidin reduce the level of apoferritin. So when the level of apoferritin is reduced, this iron cannot be stored in this form, and iron will be released into the peripheral circulation. When iron enters into the peripheral circulation, there is a transporter, and that transporter is known as transferrin. This transferrin carry iron into various parts of our body where iron is required. Transferrin can bind 2 iron at a time. Iron in the form of Fe3 is attached to this transferrin, but in the enterocyte, iron is present in the Fe2 form. So when this iron enters through this channel into the peripheral circulation on the apical surface of this enterocyte, there is an enzyme which is known as fury oxidase enzyme, which oxidizes this Fe2 into ferric form. So this ferric form of iron can be transported by this transferrin into various parts of our body. Now this is a cell. We consider this cell as erythroblast, where the process of hemoglobin synthesis will occur, and for the process of hemoglobin synthesis, iron is required. There are specific receptors on the surface of erythroblast, which is known as transferrin receptor. This transferrin receptor will bind with these. This transferrin will bind with these receptors, and the cell will take this iron as endo by the process of endocytosis. This endosome will then combine with lysosome where the pH is acidic, and due to acidic pH this iron will be released into the cell, while the transparent receptor will move back to the peripheral circulation to carry more iron into various cells. When iron is released, now depend upon the process of erythropoiesis and depend upon the hemoglobin need. If our body need more hemoglobin, this iron will be utilized in the process of hemoglobin synthesis. But if the body do not need iron, so this iron will be stored in the form of ferritin, which is a storage form of iron. This iron then moves to mitochondria, where an important step occur in mitochondria during hemoglobin synthesis, where a phylochelatase enzyme incorporate this iron into hemoglobin. So hemoglobin synthesis will occur in erythroblast. Now there are certain factors which are responsible for the absorption of iron. So these are the factors which is favorable for iron absorption, while these are the factors which reduce the iron absorption. So if our diet mainly consists of heme iron, so heme iron is directly absorbed into the cell, as we discussed earlier that there are specific receptors for heme, which is known as heme transporter, which directly transport these heme into the cell enterocyte. The other is ferrous iron form of iron, which is directly absorbed because of the DMT1 receptor present on the surface of enterocyte. Vitamin C basically reduce Fe3 form of iron into Fe2 form. Therefore, iron absorptions will be enhanced. If there are certain other factors like reducing sugar if present in our diet, similarly amino acids which have the capability to reduce iron, Fe3 form of iron into Fe3 form, so its absorption will be increased. In iron deficiency anemia, the level of hepcidin is also decreased, and hepcidin regulates the entry of iron into the peripheral circulation. Similarly, ineffective erythropoiesis. Ineffective erythropoiesis is that process in which the bone marrow is unable to produce mature cell into the peripheral circulation. So in the peripheral circulation, if there is no mature RBCs, it means that the hemoglobin level is decreased. So when the hemoglobin level is decreased, our body will need more iron. So therefore more iron will be absorbed because the body needs iron, therefore iron absorption will be increased. And similarly pregnancy. In pregnancy, the body needs more iron, so therefore body iron absorption of body iron will be increased. These are the factors which reduce the absorption of iron. For example, inorganic iron in the form of ferric form. So if more ferric form of iron is reduced, and these agents like vitamin C, reducing sugars, amino acids are not present, so if these agents are not present, the iron will not be reduced into ferrous form and its absorption will not be occur. Similarly, alkalis, certain precipitating agents like phytates and phosphates, if these are present in diet in high concentration, so it also reduces the absorption of iron. And if the level of hepcidin is increased, so iron absorption will be reduced and decrease erythropoiesis. In inflammatory condition, like certain inflammatory condition in gut, like sprue, which is an inflammatory condition, in these conditions the iron absorption is also reduced. Iron distribution. There are certain organs in which iron is stored, in certain places where iron is also circulating. So in our body, iron is present in two forms. Number one, functional iron. Number two, storage iron. So functional iron is that type of iron which is involved in performing certain function, like for example hemoglobin. Hemoglobin is responsible to carry various gases into various parts. For example, it transports oxygen to the peripheral into various tissues. So in this hemoglobin, iron is present, and this iron is responsible to carry oxygen because it forms a bond with oxygen. So this is functional iron. Similarly, certain enzymes which are present in various cells, for example catalase enzymes, cytochromes, which also contain iron. So these are known as functional iron. Storage iron, like iron which is present in the liver and iron which is present in the reticuloendothelial system. This iron is known as storage iron, which release iron if the body need iron. So in red cell hemoglobin, iron is present almost 2500 milligram. In bone marrow and erythroblast, 150 milligram of iron is present in erythroblast. In liver, 250 milligram of iron is present in the hepatocyte. While in tissues, iron containing enzyme contain 150 milligram of iron. While in myoglobin, 300 milligram of iron is present in myoglobin. So this is basically the distribution of iron in our body. Now iron storage. Iron is stored in our body mainly in the liver, in the reticuloendothelial system in the form of hemosiderin and ferritin. Both of these form of iron, these are known as storage form of iron, hemosiderin and ferritin. Ferritin is the combination of a protein which is known as apoferritin, which is the protein component like this one, while the core contain iron plus hydroxyl ion and oxygen. So combinedly this is known as ferritin. Ferritin is mainly present in the liver, in the hepatocytes, in the bone marrow, in macrophages and in erythroblasts, while in spleen where are also present macrophages, and iron is also stored in the macrophages in the form of ferritin. Ferritin is insoluble in water. As it is insoluble in water, so we cannot observe this form of iron under light microscope. A stain which is known as iron stain or pearl stains or Persian blue stain is used to observe iron and to observe storage form of iron. So if we perform a test which is known as iron stain, we cannot observe this iron, this form of iron which is known as ferritin. Ferritin is easily available form of iron. If the body need iron, this ferritin is readily available. Another important property of this ferritin is that there is a balance between serum ferritin and storage iron. So this ferritin is nowadays used for the diagnosis of iron deficiency anemia due to its balance property. Another form of storage iron is known as hemosiderin. Hemosiderin is the aggregated form of ferritin. When many particles of ferritin aggregated, they form a hemosiderin. Hemosiderin is a water insoluble form of storage iron. Therefore, if we perform iron stain, we will observe hemosiderin, which is the storage form of iron. Therefore, this is easily visible by light microscope. Another property of this hemosiderin is that the iron concentration is increased in hemosiderin as compared to ferritin, which is 37% in hemosiderin while 20% in ferritin. Hemosiderin is mainly present in macrophages rather than hepatocyte. Now, transferrin. As we discussed, that transferrin is a carrier protein which is synthesized by the liver, which transport iron to various part of the body, and it transports iron within the plasma. One transferrin can carry 2 iron. If transferrin is without iron, this is known as apotransferrin. And for transferrin, there are specific receptors on various parts of the cells where iron is required. Therefore, this transferrin carry iron for storage purpose and also for functional purpose. For example, for the process of erythropoiesis, where hemoglobin synthesis occur. So this transferrin is basically responsible to carry iron. And the synthesis of transferrin is inversely proportional to storage iron. If our body have more iron, so the synthesis of transferrin will be decreased. But if our body need more iron, our body increase the synthesis of transferrin to carry more and more iron into the tissues. Thank you so much. This was part first, and in the next lecture we will discuss pathophysiology of iron deficiency anemia.